And it's the same for thrombectomies. Those of you who work in SICU, if your patient had a thrombectomy and within 36 hours they're worse, you need to do an NIH and have it documented and let the physician know that their condition has worsened. If your patient is symptomatic, or even if they're not symptomatic, they may order the standard CT scan, right? Because what are we trying to see if they've got a bleed? Any questions on that? So this is a new measure that we started looking at for thrombectomy capable. And it's the same for, like I said, alteplase. So if you work in a unit where you're going to be receiving the alteplase, post-alteplase patient, when do we do NIH for TPA patients? Admission, 2 hour post the medication, right? 2 hour post, that's a standard, and then at 24 hour. But then you also are going to do it with any worsening, remember, with any neural change. Are they getting worse? Or if they're getting better. Because we want to know that they're getting better, right? That the medication is working. So that's that measure. And here's the same thing that I just explained to you, the rationale for it. So we are using the 2018 guidelines for early management of our acute ischemic stroke patients. And how you're going to answer this question is that this all translates into Elsevier's SCM documentation, right? You guys know where to find your CPGs on your, for the new updated KBC 5.0. So these guidelines is what's been translated. The American Heart Association has made sure Elsevier partnered with them so that the measures are the same that's in there. And you guys can all familiarize yourself with this if you want to read about it. It's you should have it in your stroke binders in your unit. And all the stuff we do for our stroke patients came from here. The neurochecks and vital signs that we do post-alteplase is in there. And here, this part speaks to your competency. So for those of you who work in the ED and the ICU, if you have taken the acute stroke emergency class initially, we went over the mixing, you should have a competency sheet. I have some competency sheets here if you're not competency in your unit and you want to see me after, because the way this works is you have to actually demonstrate back to me what I just did so that I can check you off. So please see me after if you need to be competency. This is the launch pad at home. So we have the alteplase in there, labetalol, nicardipine, nitroglycerin, IV fluids, and clofepine. So how we meet the American Heart, American Stroke Association best practices is that we have our order sets. If you're familiar with all the order sets, you probably, if you've taken care of stroke and TIA and hemorrhagic patients, you've probably seen the physician ordering these in SCM. These are all also available for downtime. On your unit, you should know what your downtime process is for documentation and where to find your forms. So what are we going to do for our patients now that we've given them TPA, they're getting better or they're getting worse? Monitoring them closely in an ICU is really important. So for that first 24 hours post-alteplase, there's a high chance that your patient can deteriorate. There's a high chance that they're going to get better. So you guys are the front line in the ICUs. You need to make sure that you are trained and certified in doing the NIH assessment, okay, and know what to do for bleeding complications. We also have a laminated sheet, and it should be in all your binders on your unit. I think I have one in my bag on what to do if your patient is actively bleeding post-alteplase or post-alteplase on thrombectomy. What are you going to do? What's the first thing you're going to do? We'll try to take care of the patient and then notify the doctor. But what if the alteplase is hanging? Very good. You're very good. So we have alteplase reversal agents that is going through the committees to be a protocol, but it hasn't been approved yet, but physicians can still order it, so it's on all your units. Those of you who work at the community hospitals, it's in the telestroke cart in their binder, and want to make sure that you have that handy. So if you're calling the ICU doctors, the EICU, you're letting them know that the patient's actively bleeding, and they will make the decision on whether to stop it or not, or to give them the reversal agent or not. So your patient's having a stroke. How many of you have seen a bleeding complication? I've only seen one since I've started this position, just one. I actually was in CT with a patient. We started the alteplase on our way back to the ED. The patient had severe aphasia. We couldn't understand anything he was saying before, but all of a sudden he said, "Ow, my head hurts." Stop the drip. We turn around and went back to the CT, because we know they're going to just anticipate they're going to order another scan and call a neurologist. Of course, he had a bleed. A lot of times they just watch those patients and don't really give them anything unless it's, it's a major bleed. But I've only seen one in the last 2 years in this position. But it can happen, but I just want you guys know what you need to do. Any questions on that? What are some other complications that alteplase patient can have? How about an allergic reaction? What are some allergic reactions patients can have? Angioedema, right? Hives, they break out in hives. Same thing, you're going to stop the medication. Notify the attending if usually these patients will either be in the ED, so you'll have an ED doctor or an ICU, right? You notify the critical care doctor, the attending. You can call if you're in the community hospitals, have somebody call and tell the neurologist, let them know you have to stop the drip because the patient's having a reaction to it. Follow your hospital protocol of treating angioedema, which is getting respiratory air to see if a patient needs to be intubated, and maybe a physician may order Solumedrol, Benadryl, that sort of thing. Any questions on that? We haven't had any of those cases here at Health First that I know of that have to be treated, but we just want you to know if that should happen, what you need to do. So don't look, yeah?
Is there going to be a protocol in the future
Yes.
for that?
Mm-hmm. Yes. Okay. So it's really important that first 24 hours of monitoring your patients in the ICU. Some other things we're doing is we have a hospital acquired conditions that can happen for any patient, right? Not only stroke patients, but they're more vulnerable because your stroke patients, what do? A lot of times if they have one-sided deficit, they can't move around a lot. So you're going to make sure that you are documenting their VT prophylaxis and make sure they're getting turned so they don't get any pressure ulcers, monitor them for any sort of infection and keep them safe from falling, that sort of thing. We do report in our stroke meetings monthly any pneumonia. What are some reasons a patient gets pneumonia? Stroke patients. Very good. Aspiration, I hear. So what is a very important thing you need to do for your patient? A swallow evaluation. You're going to do your 3 and swallow screen. If a patient fails, you're going to make sure that they have an order for bedside swallow. Thank you. Yeah. So pneumonia is one that we report in our meetings. We do catheter associated, not only catheter associated, any UTIs we report also. And there continue your ICU care, everything I told you about. Remember, these patients, if they can't swallow, we're going to make sure that we are addressing their nutritional needs, and they may need to get a drop off and get dietary on board also. We talked about the stroke order sets. I usually on day 2, neurology will see these patients and will order an MRI and order some other studies to see where the cause of the stroke. We're going to go into core measures, so I don't know if you guys want to take a 5-minute break and come back, but I really want to touch on core measures, stroke core measures. So we're going to go ahead and get started and talk about core measures. So I know we covered best practices and evidence-based care, and we talked about what is best for our stroke patients. So it's really important that you guys follow our core measures protocol, right? Orders for our stroke patients. And I'm going to walk you through where you can find all your cheat sheets. Up here, if you work in the PCU units, I have core measure cards, all pre-printed, little ones for your pockets. And I also have a laminated 2-pager that covers all the core measures from 1 to 10. So the reason I came up with this is when I'm doing my rounds and I interview staff members and nurses and I ask them what is prophylaxis for DVT. You know, we all know about STDs. But sometimes people are not 100% sure what they should be doing for their patients. Okay, so on here I have that all spelled out for you, so please feel free to take one of these back to your unit and make sure all your nurses get familiar with them. These are good to have in your pockets because if you have a stroke or TIA patient, it reminds you quickly what you need to get done. You need to, for example, you have a patient come through the ED. And this is my classic scenario because I review all the stroke patients' charts and I can tell you the ones we fall out on are usually not your typical stroke coming in with focal deficits, right? It's the ones that come in with the vague symptoms. We're not 100% sure how they're going to code out. For example, let's say dizziness, nausea, vomiting. We've been seeing that a lot. Vertigo. Blurred vision, plus something else, neuro headaches. 2 days later, they're not getting better. Somebody ordered a stat MRI, and they are positive for a small stroke somewhere in their brain. Well, if it's 2 days later, some of these core measures need to be done by the end of day 2 on admission, right? So if it wasn't addressed in the ED or on the unit in a timely manner, we may fall out on these core measures. So those are the ones we pretty much see. I know if you work in the ED, any of our EDs, there is a neuro assessment sheet that's been passing around that says that you need to do an NIH for any of your patients that come in with vague symptoms. Vague, like again, dizziness, vertigo. What are some other ones? Gait, instability, gait disturbance. Sometimes we're not sure. Is it stroke? Is it not? Do they have a history of something else? But the patients that we kind of miss are the ones that have multiple comorbidities. They may have had a stroke within the last 3 to 6 months and have like residual deficit from that stroke. So it's kind of hard to really figure out. So when in doubt, always do an NIH. So that initial NIH is really important within 12 hours of them coming to our hospital. So what I've been doing, I've been also trying to get the PCU and the ICU nurses have their awareness on those vague symptoms. So if they get a patient with those vague symptoms and the NIH wasn't done in the ED, that they can probably pick up on it and do one, you know, when the patient gets to their unit. But ideally, these patients should have an NIH done in the emergency department. And what follows at the NIH? Swallow. Very good. Who said that? She needs a brain thing. So yes, if you're going to do an NIH on a patient, remember they need a 3-ounce swallow screen. Same thing vice versa. If you think your patient needs a tree and swallow screen, chances are you need to do an NIH on them. So remember, those two go together. So here are some of the vague symptoms that I was just mentioning: altered mental status, syncope, dizziness, lethargy, headaches, numbness, tingling to the face or extremities, weakness, and it could be weakness generalized. Sometimes these patients, like I said, you may be working them up for other things. For example, sepsis. Can a patient have sepsis and have a stroke at the same time? Yes, we've seen those. So although they're positive for sepsis because you have all their diagnostic lab results are showing that, they may be having a stroke also. So just go ahead and do an NIH assessment. That's all you need. You don't have to stroke alert every patient that come in with these vague symptoms, but it's very important that we get an NIH and that tree and swallow screen. Any questions on any of these? And I've had a long list. I just want you to know where we got this list from. This list came from our own Health First patients who we've missed core measures on. We actually went back and looked at the charts and look and see what signs and symptoms they came in with that make us not, pay attention to get an NIH and a tree and swallow.
Can I say something?
Yeah.
Those symptoms are like every patient we have has. So, I mean, it's like, do we just do one? I mean, vague is like, everything else on that list I see in practically every patient I see.
So I would say
Like a
use
skin check.
your clinical judgment. Good question, though. You get to practice your NIH skills. So here it is where we talk about the best practice guidelines show that free and swallow screen and NIH should be done. Remember, you're going to add stroke plan of care if you're working your patient up for a stroke. And here are the 10 core measures that I mentioned to you. The first one is VTE prophylaxis. Remember, even if you're doing that Caprini assessment now on your patient, I think you're doing it on every patient, and they have a low risk, they still need to have VTE prophylaxis if we're working them up for a stroke. Discharge on antithrombotic therapy, that's the patients that go home on aspirin or Plavix. Some cases, anticoagulation if they have atrial fibrillation. Thrombolytic therapy specifically is the post-alteplase patients. Number 5, antithrombotic therapy by the end of hospital day 2, that is your aspirin, Plavix, or Brilinta. Stroke 6 is discharge on a statin medication. Stroke 8 is our stroke education that we give to our patients, and stroke 10 is assessment for rehab. So as I was mentioning, VTE prophylaxis must be documented. If you have a patient that SCDs are ordered on, if you walk in the room and the patient say, for example, you ask them if they want to put it on and they say, no, not right now, that is a refused. You have to document SCDs are on or refused on your patients. If it is refused, the patient don't want to put it on, you need to remind them the reason that you're asking them to keep it on. If they still don't want to put them on, make sure you notify the attending physician, for those of you who work on the PCU units. Chemical VTE examples are the heparin or Lovenox subQ. Where to document it? Here on the new KBC 5.0 documentation. When you hit that drop-down box that says VTEP prevention management, if you check off that little box that says patient refuse intervention, you can put on the bottom free text, what did they refuse? They could refuse Lovenox also, right? They could refuse their heparin. I've seen cases when I review the charts, a patient refused their heparin, so make sure you put it in there so we can know. But we still go that step further and we'll look at your EMR and see which medication, if it was a medication that they refused. Any questions on that? Okay. And again, this has to be addressed before the end of day 2. So, here's a scenario. Your patient walk into the ED at 11:59 p.m. At 12 midnight, day 1 is over. They're not even admitted yet. Probably they're not even triaged yet, right? But they're banded that they arrived at 11:59. So day 1's already over before your patient's even admitted. So when we say you have 42 days, just know that that arrival time is really important. Any questions on that?
So it's 2 midnights, not 48 hours.
That is correct. 2 midnights. And the reason I said not admitted is sometimes I would have nurses tell me when I'm rounding and I talk to them about the core measure, well, the patient was not admitted until 2 o'clock this morning, but they were in the ED at 11, before that midnight hour. So although they're not admitted, they're still in the hospital and we still have to have the core measure addressed. So this is for the post-alteplase patient. Remember, these patients also need to have VTE prophylaxis addressed before the end of day 2. So if your patient was given alteplase for 24 hours, they can't have any blood thinners, right? Which is antiplatelets, anticoagulants, anything. They can't have any of those. But they can have SCDs on. So if you don't have an order for SCDs, please make sure you get one, have it put on them. The same rule apply, it has to be documented on or refused. Or if it's contraindicated for some reason, maybe they have clots in their legs or something like that, make sure that a doctor document that it's contraindicated. So these are your patients. The stroke 2 is your patient that come in and you're working them up for TI or stroke. Before they leave the hospital, we have to have a physician document that they're not going to start them on an aspirin or that they're on it and they've been given a script. And if a patient's already on maybe an anticoagulant like Coumadin or Xarelto or Eliquis, sometimes a physician will say, that covers everything, they'll write that in their notes. So we usually, when we are abstracting the charts, we look for these documentation. But just so you know what we're looking at when we look at core measures. So stroke 3 is anticoagulation therapy, and these are the patients who either come in with AFib or have a new diagnosis of it. They need to be started on an anticoagulation medication, or a physician can document a reason why they don't want to start them. What are some instances a physician will document they don't want to start a patient on these? Yes, if they had a GI bleed, if they've had maybe a subdural hematoma in the past year or 2. How about our older patients, the ones that are high risk for falls and such? Sometimes they don't want to, they don't want to start it on those patients because they're a high risk for falls. They figure they'll fall, come in with a head bleed and that sort of thing, but they need to document that in their notes. There you go. That is a really good example. I have to tell you how many, and that in that case scenario, where patients on an anticoagulation medication and they were getting ready for a surgery, they take them off it. What are those patients at risk for? A stroke. How many times we've gone to rapid response on the inpatient side and patients just come off their anticoagulation therapy and now they're having stroke symptoms. Yes. So did you hear that? She said patients that have a factor V deficiency, and there's some other ones also in rare cases. Yeah, so they will not anticoagulate those patients. But as long as the doctor documents in their notes a reason, that is good. So these are the patients that, and this is important for the ED and ICU nurses. Any patient that arrive to the hospital, actually mostly for the ED, because it talks about arrival to the hospital. If a patient arrives within 2 hours of their symptoms starting, we have to offer TPA if they meet the criteria. So if it's not offered, then neurologists or teleneurologists have to document a reason why. So we have a spreadsheet where we keep track of all our stroke alerts. And on there, if some of you, if you're a manager of a unit and you have access to that, if you go in there, you will see that I document things like outside alteplase window or patient on an anticoagulant. In some instances, we will document patient refuse. Actually, yesterday I was reviewing a chart, and patient's son refused to have his father have the medication. He knows somebody and some friend of his that had a family member who's had a really bad reaction to it, so he didn't want his dad to have it. So in those cases, it has to be documented by a doctor. So stroke 5, again, is antithrombotic therapy by the end of hospital day 2, and these are the patients that need an aspirin. So let's talk a little bit about antithrombotic. There is sometimes a confusion amongst nurses. What are antithrombotics? Aspirin, Plavix, Brilinta are considered what? Antiplatelets, right? They're also antithrombotics. Coumadin, Xarelto, Eliquis, Pradaxa. They are anticoagulants, but they're also antithrombotics. Does that make sense? Okay. And I think if you need a list, let's say you're on a PCU unit or you're on a med-surg unit where you see stroke patients once in a while, we can get a list from pharmacy for you guys. Okay? So just reach out to me and I can have that emailed to your unit and you can post it so your staff are familiar with it, with the medications. So remember, for those ICU nurses, again, that antiplatelets need to be addressed after that 24 hours. Because usually once the patient have that 24-hour CT scan done and they don't have a bleed, the neurologist will see him and will start their aspirin at that time. So we want to make sure that they have that at least before they leave the hospital. Every patient that gets worked up for a stroke needs to have an LDL done, and if their LDL is greater than or equal to 70, they need to be on a statin medication, or a physician can document a reason why they don't want to address it. Sometimes I'll see documentation such as, we'll defer to primary care on discharge, and that is good enough. Sometimes they don't want to start a patient on a new med, well, you know, it depends on the patient's age and comorbidities and what's going on with them. So just a reminder for you guys that if your patient's LDL is greater than 70 and a statin medication hasn't been addressed with them, just ask the doctor, are we going to start a statin? Or if not, just remind them, can you please write that in your notes? Stroke education. We have a stroke book, and it should be in the ICUs and PCUs. Understanding Stroke, a guide for patients and caregivers. If you need any of these books, please reach out to us. I'm willing to bring it to your unit if you get stroke patients, so you can give this book to them. Even if your patient is not positive for a stroke and they are high risk for having a stroke, can you give them stroke education? Very good. So, we have these flyers. It's called Stroke Prevent Treat Beat. If you work at homes in the PCU unit, they give this to all their patients in their welcome packet. All their patients get stroke education. On the back here, it has a stroke risk quiz. If they have high blood pressure, high cholesterol, if they smoke, have atrial fibrillation, diabetes, overweight, any of that, and it gives them a score to see if they are high risk for having a stroke. I remember a couple of years ago at Cape Canaveral Hospital when I was sitting with a Joint Commission surveyor and we were reviewing our stroke program. She said to me, "You guys do a great job taking care of stroke patients, but what are you doing to prevent stroke in your community?" So that's where this came from. So, if you work in an ICU, PCU, med-surg, wherever you work and you think that your patients might benefit from these flyers, we get these from marketing. They print it for us, they can probably print it for you and you can give it out to your patients in their welcome kit. Every patient that come in the hospital can get that, okay? And if you need it for, for maybe a community, if you belong to some community organization and you think they can benefit from that, please let us know. So when you document stroke education on your patient, you're actually saying that you tell them the warning signs and symptoms of a stroke. And they also know when to activate the emergency medical system. In the book, it explains the disease process, if they're having an acute ischemic stroke or a hemorrhagic stroke, and what they need to do to follow up when they leave the hospital. Also in there, it addresses what medications they should be going home on and risk factors that they need to modify. So there's the book. Here's the TIA flyers, and we can get some of these to your units if you need it. The TIA flyers also come in Spanish. So here's where you're going to document. So you have a stroke or TIA patient, you're going to make sure you pick the plan of care of stroke. And you're going to document accordingly. If you scroll all the way down to the bottom where it says literature and videos given, you need to make sure that little box that says stroke is checked. The reason I'm telling you this is I've seen cases where people go in here and they just free text stroke. That doesn't cover those 5 things that I just mentioned that we're saying we're doing for the patient. And let me show you why. I think I have it on here. You'll see this little screen up there will say patient given stroke education, but this is what you're saying when you hover over it with your cursor. It says here, patient given stroke education on signs and symptoms of a stroke, risk factors and lifestyle changes, stroke warning signs and early access to 911 when symptoms start. Education included discharge medications and community resources and the need to follow up after discharge. Instructions include avoidance of all tobacco products and avoidance of secondhand smoke. So that's what you're saying when you check that box, just so you know, because you don't always see that. The last core measure is rehab. Remember, any patient that come in for a stroke and have a positive stroke need to have a rehab address. If their symptoms have resolved, that's all good, but the physician have to document in their progress note that no rehab needs identified. So for those patients who get PT order, those patients need to have an MRS course. And an MRS, a modified ranking scale score, is documented by our physical therapists when they see the patient. Also, I think soon we're going to be upgrading SCM to have me and maybe nurses document an MRS. So what an MRS score is how your patient is going to, how they're going to be able to go back to the life they had before, right? What deficits do they have, or what needs they're going to have on discharge, that sort of thing. So I'm going to show you what the scale says. So an MRS of 0 means your patient have no symptoms at all. It's like an NIH of 0, right? So when I say nurses can document this, if your patient's symptom completely resolved and you've done an NIH and your NIH is 0, their MRS is a 0. Does that make sense? So 0 means they have no symptoms, they're back to baseline. And don't look at number 6. Yeah. So that's what the MRS, I just put that in here so you guys know when you're reading your the physical therapist notes and you see MRS score, you know what that means. So this is what it means. So that's how they assess the patient for their needs. So when you're talking to a Joint Commission surveyor, you're going to sound really smart if you know what the MRS scores means. And you can say, I know what the MRS scores mean, right? Any questions on that? So start looking in your patient chart and look for the MRS scores. Every stroke patient should have an MRS documented in your chart before they're discharged. Oh, and one of the things we do in my department also, I personally call all the TPA patients and the thrombectomy patients. I have to call them within 7 days of discharge. And we have someone who make 30, 60, 90-day calls for us, and when we call these patients at home, we do an MRS score on them. We kind of have specific questions. We ask them to give them a score, like, for example, can you prepare a meal for yourself? Can you get around by yourself? Do you drive? Can you drive? Do you need help? How much help do you need? What do you need help with? That sort of thing. Who is helping you? So we try to get a lot of information to see where they are on that MRS scale. So last but not least, remember there is a best practice checklist under your neuroscience tree and FirmFast. Print. I have one here. It's all laminated for you. So if you want one of these, please come see me, because I want you guys to have all the tools you need to do your job. And the back, I have laminated the best practice checklist. So if you have a stroke patient and you're in a unit where you don't get stroke patients often, like the med surgery, make sure you go to FirmFast and print this best practice checklist. It has a stroke core measure on this one side, so you will not miss anything on your patient before they're discharged. And it says here, when discharge is complete, you can turn this in to your manager. It's not a legal part of the chart, but it's just a reminder so that you don't miss anything, okay? So that's what that best practice checklist is. And here it is also. What are you going to do if you think your patient's having a stroke? Call the HOC. Make sure that you put your patient on the stroke census. Implement all the stroke core measures as soon as possible. If you are in a non-neuro unit, request that your patient get transferred to a neuro unit, right? For those of you who work in med-surg or other PCUs in the hospital, if you have a stroke patient, you know that the nurses on the neuro unit are familiar with stroke patients, you can request that they get transferred. It may not always happen based on, bad situations and that sort of thing. You can also call me and ask me questions. I want to make sure that you guys call me ahead of time rather than me calling you when there's a fallout. And I have the steps on how to put a patient on the stroke census. So I know across the IDNs, we've been asking that some charge nurses, relief charges, get access to HBOC, but I think we're gonna have some good news, right, Nancy? We've been working with clinical informatics. I think there may be a way to put patient on from SCM. But I will let you know more to come on that. We haven't really gone through the whole process yet to see how that will look and how it will work. We're trying to, to make your life as easy as we can. Any questions on putting a patient on the stroke census? If you need little cheat cards, I have a stack of them. I can give you You know, all your hops should have access to putting patients, you know, to HBOC so they can put patients on stroke census. Do you guys have any questions or concerns about anything you've learned today? Anything we could clarify for you? I want to thank you very much again for taking good care of our stroke patients. Yes? They have to go to ICU. Good question. Yes. Yeah. If you need to be competency for TPA, please see me. I can review the steps with you. After